Okay, so in the next half hour, we're going to talk about talking therapies, and we're going to think about, more specifically, about 3 different types of talking therapies: counselling, psychotherapy, and CBT. And we're going to see how these work through the lens of a case study called Anna. Okay, so what do we mean when we say talking therapy? Well, really what we mean is talking to a trained therapist about our problems with the aim of reducing suffering and distress. And also, keeping in our experiences, not talking about these experiences, can increase our suffering and also increase our pain. So a quote just taken from the Mental Health Foundation website: having someone to talk to who is not connected to any of it means they can look at things from the outside, which helps. You can explore and explain the situation better. Okay, so talking. How can talking help? So let's have a look. We've all heard that old adage, problem shared is a problem halved. So we know that talking can just acknowledge to ourselves that there is something that's causing us difficulty. We know that one of the unhelpful coping strategies we can use quite a lot is denial. We can start to understand what's causing the problem. There might be a myriad of things, and by talking about it, we can perhaps focus on one particular thing that can then evoke change. But also we can validate our experiences as something that's worth addressing. I mean, the number of people I say, well, I think, wow, that's quite a lot that's happened in your life. And they say, has it? I said, yes, that's not normal. And they say, oh, okay, I've just lived with it so long that it just seems kind of like an everyday thing. But people can feel really validated just to hear about their experiences. And also just giving words to the way that we feel. We know from David Rock, who wrote Your Brain at Work, he says just giving a name to the intensity of feeling that we're experiencing can reduce the distress. It can dampen the arousal mechanism in our brain. And also we can change perspective to a more useful one. I mean, quite a lot, with my a lot of clients recently, I've been talking about guilt. And I've had clients come in saying, you know, I feel really guilty because this thing has happened to this other person. I'm thinking, is that guilt? Or is that something else? And then we talk about it, and actually it's something else. It's sadness, it's regret. Yeah, it's empathy because you care, but it's actually not guilt. And just by calling it by its proper name can reduce the suffering, because it means that somebody can let go of blame. They can let go of holding themselves responsible for something that they weren't responsible for. Okay. But also talking about it, you know, we're social animals. We exist in groups and relationships with other people. We do well as a species when we interact with people. So actually talking to people, talking about our problems can help other people understand. Talking can help us create a distance so that we can then look at the problem in a different way and do something about it. And it helps us maintain relationships with other people. And also sometimes we can experience something so overwhelming that we don't know how to process it. And talking is a good start just to try and make sense of what we've experienced. And also we can come to some difficult things happen in our lives. Sometimes we lose somebody close to us. And then talking about that can just help us process that experience. Okay, so the therapist helped me with positive steps in getting me to recognize what I had achieved in life. I felt less like I was to blame for feeling the way I did. Okay, so we know that there's stigma about mental health, particularly in this country. And we feel that, you know, if I've got a physical problem, I can go and see a doctor. If my car's not working, I can go to the garage. But psychological health, emotional well-being, I don't know. If I go and see somebody, does that mean that I'm mad? Well, actually, I mean, we've had a lot in the media recently with people starting to talk about these experiences. People starting to normalize that actually we all have psychological difficulties. And so actually wanting to get help with these difficulties is not a weakness. Okay, so 3 different types of talk therapy: counselling, psychotherapy, and CBT. Now, there's a lot of confusion around these because they are often used interchangeably, not just by the layperson, but also by professionals. So I'll now talk a little bit more about what they do and the distinct differences between them. But we know that these therapies can help with a whole range of problems, from depression, anxiety, addictions, phobias, anger, bereavement. Sometimes it's more useful to talk about what they don't help with. Okay, now within the models themselves, there are a whole range of different therapies. So when you go to counselling, you can have different types of counselling. You can have person-centred counselling, couples counselling, relationship counselling, bereavement counselling, Rogerian counselling. Psychotherapy has got lots of different models. So we've got psychoanalysis, CAT, cognitive analytical therapy, DIT, dynamic interpersonal therapy. And also with CBT, we've got a whole range of therapies. We've got acceptance and commitment therapy, which is a mindfulness-based therapy. We've also got compassion-focused therapy. And we've got mindfulness-based cognitive therapy. So this is the case study, and we're going to look at how counselling, psychotherapy, and CBT would look slightly differently through the case of Anna. So let's have a look at Anna. So Anna's 24 years old, has a diagnosis of hypermobility spectrum disorder. She's got POTS, anxiety, and episodes of depression. She's a perfectionist. I've heard that word a few times today. And she's just got her dream job in the city in finance. However, in relationships, she doesn't do so well. She struggles ending relationships, and she tends to be in unhelpful relationships with men who seem to be unemployed and really struggle in life. But when they end, she feels absolutely suicidal. She's currently off work as she's got too much pain, and fatigue and joint pain, and widespread body pain. And she has frequent subluxations. She's got difficulty sleeping, and her sleep is generally non-restorative. And she really worries about her job in the future because of this diagnosis. Now, in terms of her past, her mother was a functioning alcoholic, and her dad was very passive. He was an academic who was always in his study, and he rarely acknowledged her. And despite all of her efforts to gain attention and look after him, often she would be ignored. She's got a younger sister who was born with a heart defect and received a lot of care and attention. And she's also got a recurrent nightmare about being left. Okay? And this relates to a memory when she was 5 years, when she was left on a bus by her mother, who was drunk. Okay. So let's look at counselling. So counselling is, it tends to be non-directive, and it tends to be kind of like, all therapists use counselling in their therapies, but anybody can call themselves a counsellor. So if you're looking for a counsellor, we'll look about later on how you could find out a counsellor, but they tend not to advise. They tend to just follow you. They will just follow whatever you're talking about. They're less interested in diagnosis and more interested in how you understand the problems that you're experiencing. And the approach they come on is actually you, as the client, you're the expert, you know what you need to talk about, and they will just follow you and support you and witness what you're talking about and help you reach a different understanding. Okay, so how might counselling help Anna? Okay, so in counselling, you might just talk and reflect on how she's currently feeling and how she feels about her diagnosis. In counselling, you would just acknowledge the pain and the frustration she's experiencing as understandable. And you might start to make sense of that question that we all ask ourselves, which is, why me? And she might understand that actually there's no answer to that. So continuing to ask the same question that has no answer might not be so useful. And she might explore why she tolerated her last relationship for so long. She might explore her relationship with her parents. And at the end, she might feel a certain level of acceptance about her current predicament. She may not be happy with it, but once she's reached a certain form of acceptance, she might start to behave in a different way. But she may be able to feel that she's able to let herself express her emotional pain, something which she was not willing to let herself do. And that it's okay to be tearful. And she may feel more comfortable being able to reflect on how she feels and understands and why she feels the way that she does. Okay, so just on a practical level, so the focus is on feelings, relationships, and just understanding our problems and just giving words to how we feel. And we might be encouraged to just sit with emotional pain. So the qualifications, there are no formal qualifications. Anybody can call themselves a counsellor. So if you did think counselling could be useful, do visit the BACP, the British Association of Counselling Psychotherapy, and they'll have a register of qualified and trained counsellors. The cost is generally between £10 and £70. The length of therapy could be, it can be open-ended, it's not specific. Maybe 3 sessions on a very specific problem, but it could be 12 sessions. In the NHS, it's probably going to be about 6 to 12 sessions, but it could be ongoing. Okay, psychotherapy. So this tends to be an umbrella term for all types of talking therapies. So, your GP might say, go and get some psychotherapy. But from a psychology point of view, the psychotherapy has a very specific definition because it comes from a very specific development and orientation. And generally, when we're talking about psychotherapy, we are referring to the works of Freud, so Sigmund Freud and Anna Freud. We're thinking about Jung, we're thinking about Klein, and quite often we're thinking about attachments as well. So psychoanalysis is one of those words that is very much associated with psychotherapy. Psychoanalysis where you're perhaps lying on a couch and you're freely associating what your problems are. Psychotherapy is often seen as what we call an archaeological therapy, in that we are really interested in the roots. So if you go and see a psychotherapist, quite often you will be talking about the past and your childhood and your relationship with your primary caregivers, namely your parents. Very good for treating recurrent depression, personality disorders, problem behaviours such as addiction or eating disorders, hypersexuality, low self-esteem, and identity issues. Very good for identity issues, and also relationship issues and attachment. Okay. So with psychotherapy, they're really interested in understanding patterns of behaviour. Yeah. People come with a problem, and they would say that actually the way you're behaving as you're behaving is rooted in your childhood. And that's why a lot of the talk will be around some of the things that have happened to you as a child. And also, it can be useful to see a psychotherapist if you're wanting to explore relationships. So for Anna, why do I keep falling for the same men? Why do I keep finding myself in abusive relationships? That's perfect for psychotherapy. So it tends to be longer-term psychotherapy, and the reason why is because so much of the emphasis in psychotherapy is based on the relationship that the client has with the psychotherapist. Okay? And the idea is that actually, as the relationship grows stronger, some of the problems that happen to the client in life start to come into the room. So a perfect example of that is the client who's always late. And the psychotherapist might ask, well, you're always late. Does this happen to you outside? And the client might say, yes, it does. I'm late for everything, and my friends get really annoyed. And so you might start to explore why that person is late. And usually something's happened in your childhood, and you'll probably find out. Now, there's a big emphasis in psychotherapy on the development of ego strength and identity. Now, sometimes you can come in, particularly if you're having lots of relationship problems, with very fragile egos. And through strengthening the relationship with your psychotherapist, you're strengthening your identity. And the idea is that once you've experienced that strength in your relationship, you can take that outside the clinic room and start applying that to your real life. Okay, so let's look about how psychotherapy could help Anna. Okay, so first of all, you would be working on a thorough understanding of Anna's life. And psychotherapists are very interested in not just what's being said, but what's not being said. So Anna might be talking a lot about her mother, and then the psychotherapist might say, it's really interesting, we've talked about your mother, but I don't know anything about your father. Why is that? Why can't we bring your father into the room? Just tell me about your father. Okay. So the psychotherapist would be asking Anna extensively about her childhood and her relationships to her parents. And she might start to gain an understanding about how this influenced the rest of her life. She might understand about her disrupted attachments and how they affect her life. What was the impact of having a sister who had lots of medical concerns? Where was the attention as a child? Were they along my sister? Okay. And on top of that, your dad largely ignored you as well. Yes, absolutely. So what sense did you make of that, and how's that affecting your current difficulties now? And you might start exploring about how relationships end, why she feels suicidal. And actually what we might discover is actually the trauma that she experienced at the age of 5 when a mum left her on a bus gave her a powerful feeling of abandonment. And whenever a relationship ends, that feeling of abandonment is activated. And it's so intense that suddenly thoughts of, I need to end things, come into Anna's life. Okay. So you'd be doing exploring, naming and expressing feelings and problems. Start to understand how these unhelpful patterns of behaviour emerge. Again, having a successful relationship with the psychotherapist enables her to start building some successful relationships outside the clinic room. And she's better able to start tolerating intense feelings of abandonment when they occur. Okay, so just on a practical basis, psychotherapy, again, the focus is on anxieties or the anxiety behind depression. We're thinking about childhood attachments and experiences, and we're also thinking about strengthening people's identity. Qualifications, so psychotherapists tend to be very well trained. So they tend to have at least 4 years training on top of having a degree and a number of years clinical experience. The cost, slightly more than counselling, £75 to perhaps £185. If you've got it on the NHS, it could be free. You might get 6 or 12 sessions free. Or if it's means tested, you could be looking at £10 to £25 per session. The length of therapy tends to be longer. And you're looking at the least in certain models like DIT or CAT, 16 sessions. But it can easily be a year, and that's because it takes that long to really build up that relationship. Okay, CBT, cognitive behavioural therapy. So CBT, in a sense, much more interested in diagnosis than some of the other models. And that's merely because with CBT, there are a number of protocols that have been developed that are very effective for things like social anxiety or obsessive compulsive disorder or body dysmorphic disorder. So it's quite important that the CBT therapist does know what the diagnosis is. So what is the C in cognitive behavioural therapy? I remember starting university, the first day I was thinking, I'm doing a psychology degree and I have no idea what the word cognition means. And so I looked it up, and it's any mental activity. So wishing, worrying, catastrophizing, obsessing, hoping, ruminating, imagining, praying, assuming, believing, dreaming, and many more. Anything you do with your mind is cognitive. Okay. And then the B is behaviour, the things that we do in response to how we think and how we feel. And quite often in CBT, we're looking at helpful behaviours and unhelpful behaviours. And typically, a number of the unhelpful behaviours that seem to emerge are around avoidance, withdrawal, and perhaps doing too much or doing too little. And so we'll look at that in the case of Anna in a short while. Okay, so with CBT, we're really trying to simplify things. We can come with a whole myriad of symptoms, but we want to make things simple. And so with counselling and psychotherapy, there will always be some sort of conceptualization or formulation. Within CBT, that formulation will be explicitly shared with the client. Often we'll draw a diagram on a piece of paper and share it with the client. And we'll try and get their input saying, is this what's happening to you? Are all these things feeding into your problem? So I'll show you a formulation now. This is a typical CBT formulation. So we call this formulation a hot cross bun. And so in a sense, we're trying to break down any experience that we're having into 5 areas. Our emotions, how we're feeling. Our cognitions, how we think. So how we use our attention. Any unhelpful thinking patterns such as worry or rumination. Any beliefs that we have, any assumptions that we hold, any rules that we hold, self-criticism, and perceptions about illness. And also physical symptoms. How do we feel because of the emotions that we're feeling? Pain, fatigue, sleep, and of course behaviours. Avoidance, checking behaviours, unhelpful coping behaviours. And it's all in the context of the situation. So once we've mapped this out and we can start to understand what's feeding the distress, we can then say to the client, what should we focus on first? So the aim really in CBT is to identify and address unhelpful cognitions, identify and address unhelpful behaviours, and also, to some extent, managing physical sensations. So, for example, if someone's coming in, I'm just really, really tense, then we might actually do some relaxation, or might even do some mindfulness. Okay, so cognitions. Okay, so from my point of view, a cognition, it's either helpful or it's not. So there are many ways that we can use thinking and thoughts, and here's just a couple here. So sometimes we try and identify unhelpful thinking styles, such as black and white thinking. So it's like, your children are lovely, you're a wonderful mother. I'm the worst mother in the world. That's really black or white, and nothing in life is really that simple. So we might want to identify that and actually modify that slightly, because it's unlikely that you're the worst mother in the world. And it's because the worst mothers in the world tend not to identify or acknowledge that. We've got catastrophizing. Okay, yeah, if I don't go to work soon, I'll lose my job, and if I lose my job, I'll be able to pay the mortgage. If I don't pay the mortgage, I'll be destitute, I'll be out in the streets, and I'll be living in a cardboard box in an alley. That's catastrophizing. And of course, we can address this in the sessions. And then we've got worry. So I had a client the other day who said, yeah, my partner's really laid back, so I have to worry for both of us. What? Why are you worrying for both of you? What about if you just worry for yourself? What would that be like? Oh, I've never thought of that. I didn't know how to do that. So we might do that in the session. Do that for a week. Just worry about yourself for a week. Come back, tell me how that was. If you didn't like it, you can go back to what you were doing before. Yeah. And of course, behaviours. Behaviours, either helpful or they're not. And quite often we find with, particularly the population around hypermobility, we find so much perfectionism. So excessive standards, people doing too much. And we might think, I'm working so, why are you working so hard? It's excessive. It's because actually it gives me a sense of, it lifts my self-esteem and I get a sense of achievement. So we might think, yeah, but the demands that you're placing on your body are too great and you're suffering. So we might think about, okay, what would help here? And then we might think about pacing. So if you're pacing, you're still doing the things that give you a sense of achievement, actually, but you're just approaching it in a slightly different way that doesn't put so much pressure on your system. Other interventions that we might do as CBT therapists would be just working on sleep hygiene, improving somebody's quality of sleep, addressing acceptance. Acceptance is a big issue for people with long-term health conditions, particularly chronic pain. I'm just defining what acceptance is, because most clients will come in and we'll talk about acceptance. I can't accept this condition. Why not? Because it's giving up. We say, okay, so you think acceptance means giving up. To us, it means something completely different. In terms of accepting, what we want you to do is accept that there's a problem, accept that there's a condition. And if you can begin to accept that, we can start to think about how you can manage it more appropriately. So then people say to me, so I've got to accept that my life is over and that I'm going to spend the rest of my life in a wheelchair. No, I'm not asking you to accept that. What I'm asking you to accept is just what's happening in the present moment. I don't know what's going to happen in the future, so I'm not necessarily asking you to accept that. Just accept that there's a problem now that needs addressing. And of course, we come across hopelessness and motivation, which will be a barrier to our work. And we might start to think about, okay, well, what doesn't make life meaningful? You have this condition, you can't get rid of it, but what would make life meaningful? What did you do in the past that gave your life meaning? How can you get some of that now? And just anything that we can just help the person take a step forward. Okay, so how could CBT help Anna? Let's just have a look. First of all, we'd be asking, from the formulation, what problems do you think we should work on first? You might say, managing pain in order to get back to work. Okay. So we might be thinking about pacing. And before we can even start pacing, we might have to tell Anna what pacing is, why it might be useful, and just thinking about helping her understand why it might be useful to pace. We might try to improve her sleep so she's not in so much pain and so much tiredness. And we might want to reduce worry and catastrophizing, manage depression, help her learn strategies to relax and manage perfectionism, and address that trauma, the trauma about being left on a bus when she was 5 years old. Okay, so this is the formulation that we have for Anna. We've got emotions, anxiety and depression, but look at the cognitions. I don't matter. You think, well, where did you learn that? Well, when my sister was born and everybody looked after her, I learned that I didn't matter. I'm not good enough. I don't deserve good things. This is why I get into relationships with people, because I don't deserve any better. I bought this in myself. People don't like me. I'm boring. We've got the inner critic that we need to address. If I don't look after others, I'm selfish. That was the message she got as a child. But how's that helping her now? She's got the physical symptoms of pain, fatigue, not sleeping, and then we have the behaviours, perfectionism, doing too much for others, being too passive with boyfriends and not eating regularly. So just in terms of some more specific interventions, we might look at I don't matter. We might think about, okay, I don't matter. I think that's a problem. What don't we do with decisional balance matrix? Really, we're just looking at what are the pros and cons of having that belief, I don't matter. Pros. I don't matter. It's useful I have this belief because it means that I don't rely on other people, and so I don't feel disappointed when they let me down. Okay, I can understand that. What about the cons? Well, it means I just don't look after myself because I don't matter. So you think, okay, this is a problem. Why don't we start developing an alternative belief? What would you prefer to think about yourself? I matter. Okay, how much do you believe I matter on a scale of 0 to 100? 0 being no belief at all, 100 being a certainty. So you might say 10%. Okay. So, okay, why don't we try a little experiment? Why don't you act as if you matter for a week and see what happens? So you might say, okay, what does that look like? Okay, well, you tell me, what does that look like? If you mattered, what would you be doing differently? Well, let's say Anna says, I think my eating would improve, actually. Okay, well, let's look at your eating. So we look at eating, and we find that she's got some difficult rules around eating, which is kind of like, breakfast is not necessary. Breakfast is for wimps. So, okay, well, that's an unhelpful belief. How about and we might do some psychoeducation about how important it is to put good fuel in the system. You know, if you've got a nice car and you're putting rubbish fuel in, you're not going to get the best out of that system, that car. So what about if we kind of like have good fuel? What does that look like? She comes up with, okay, breakfast snack, lunch snack, dinner snack. And then I might say, okay, so what would you eat for breakfast? Even if it's half a piece of toast, fine, let's start there. Snack, small handful of nuts, lunch, some soup. Do that for a week, and let's see what happens. So she does that for a week, comes back. Okay, that belief, I matter. How strongly do you believe that now? She might say, 15%. That's a win for me. I mean, it's still quite low, but actually, if we do a number of things, if she acts as if she matters, yeah, slowly that's going to start to improve her mood. But what she's going to notice is that she's managing much more effectively, and actually the managing is going to help her self-esteem. So they're just a couple of interventions that we use, and there can be many, many others, and we're guided by the intervention. And just the last slide, just practically, in CBT, the focus is on the here and now. We can be interested in the past, but only to understand what's going on in the present. So we don't spend too long talking about childhood. The qualifications, so all CBT therapists should be accredited or qualified with the BABCP. The cost tends to vary between £60 and £200. And a typical episode of treatment is between 12 and 16 sessions, and it's usually weekly or fortnightly. And in the limited time I've got, that's it. Thank you for listening.
Okay, can I welcome back our speakers, please? It's Phil and Linda here. And Alan, thank you. If anyone has messaged Dr. Hakim directly, he hasn't been able to see them because he's been busy at Hedge all day. So either resend them on the subject or stand up by microphone because I won't be able to see those messages. Okay, we'll start over here in the centre. Thank you.
Hi. I work as a psychodynamic psychotherapist, so I work with adverse childhood experiences. I also have HSD. And I have a concern in my work about GPs referring clients for anxiety and depression. And because I have what I have, I'm able to work out that the symptoms, some of the symptoms they get are physical and not mental. So the concern is if I didn't know what I knew, there would be some therapists carrying on with the whole anxiety. Now, I'm not saying there's not anxiety there, I'm talking about specific symptoms. And when I've said to my clients, go back and see your doctor, because that's not an anxiety symptom. I've been doing this 15 years now, so I work out what's what. They go back to the doctor, I say, you need to go back and get a referral to find out what this is. And they find out what it is, and they come back and say, yeah, it's some problem with my stomach, and it refers to EDS or HSD. So I just wonder if you've had those experiences, and how do you get the message through to GPs or any other medic that they're causing problems there by just assuming that their clients have anxiety when they don't?
There we go. That happens all the time, actually. That's really common. And because, in a sense, GPs are not so good with chronic pain, medically unexplained symptoms. With chronic pain, the best that they can do is, often give painkillers. So it's very difficult. So they're always looking for somebody to shed some more light on it. And I think it's our job to think about, okay, we've done an assessment, we think some of this is physical, and maybe it's our job actually to contact the GP, send a letter back, and by doing that, we're educating the GPs. Sometimes I go, where I work in my NHS practice in Kingston, I go to the GP kind of like seminars, and I talk about kind of like EDS, because I'm just trying to increase their knowledge of it. But in terms of their training, they wouldn't have had anything on EDS. So I think it's, again, it's one of those things where we're slowly educating people through lots of different means, but I suppose we do have to take on the task of actually educating the GPs.
It does work. So absolutely concur. It happens all the time, every day, every clinic. That's that story. And it should work both ways. So if I see somebody who comes in and much of what we discuss is a realization that there are lots of psychological issues and maybe less on the physical, then I should be able to just have a completely normal, mature conversation with somebody from psychology or psychiatry, wherever the support's needed, to say we need some help and we need to work together to, to support this person. So it works both ways. But the thing that I find the most distressing, to be honest, is when somebody is sent to a psychologist or a psychiatrist, and the psychologist or the psychiatrist says, fundamentally, this is not a psychological or psychiatric problem, it's a physical problem. And when the individual goes back to see the doctors, they completely disbelieve the report of the psychologist or the psychiatrist and continue to pursue this avenue of it being a psychiatric issue. And I just do not understand that at all. And that tells me that in those sorts of situations, this experience and understanding of the physical issues is just completely lacking. They just don't have the skills. Now, I am the first person to say it's fine not to have the skills. It is not fine to ignore the fact that you don't have the skills and continue to pursue that pathway. It's completely inappropriate and it's bad for patients.
We've got a long way to go. I've had two experiences of talking in London to the Medically Unexplained Symptom National Group and also local psychiatrists. And it's very interesting just seeing how the pennies start to drop when you present the story that we have. And it does mean that we've got to do a lot of education. We do, with the HMSA website, we have a meeting in a box that you could tell your GP about. Because what we think, I think we all agree that it has to start with GP education. That's where it's got to be, because a lot of the less severely affected individuals just want a diagnosis and don't necessarily need a lot of intervention. They just want to know, why have I got all these symptoms? So I think the whole issue of somatization as a philosophy for psychiatrists is a big worry.
Okay, question for, yeah. Question for Alan. In using beta blockers, how about using something more specific such as antenolol that is beta-1 specific, easier on the lungs, and does not cross the blood-brain barrier, so it's a non-sedative? The idea would be to break the feedback mechanism of perceived increases in heart rate, increasing symptoms of anxiety further.
So who's been reading up on their beta-1 and beta-2 biology? Well, no, I mean, absolutely. I mean, atenolol is in there on the list. Agents like metoprolol and bisoprolol are often used because they're actually better tolerated for the various types of side effects that there can be. But there's no reason why you can't use atenolol as a perfectly reasonable beta blocker. They've all got beta-1 activity, and the first two have got some beta-2 activity. So I don't know who asked the question, but it's perfectly reasonable to use atenolol. Thinking about agents that are used for beta blockade to control blood pressure in things like vascular, EDS, metoprolol and bisoprolol and celiprolol are the sort of more typical ones to go for because they've got much more multi-receptor activity.
Thank you. And this is not a question but a comment that some people may find helpful. In addition to the BACP, the professional body for counsellors in Scotland is COSCA, Counselling and Psychotherapy in Scotland, and they have a list of accredited counsellors on their website. Okay, bear with me please while I just go through the questions. Oh, hello, there we go, go on.
Are we there now? Can I just say that it's not very easy to stand up here and make this comment, but I'm going to do it anyway because there is a purpose for me, the same as everybody else, to be standing here. I want to put to the panel just exactly what's your opinion on trauma induced by professionals to families out there that are struggling to get any help and support. I was in a position myself after 9 years of looking for assessment for my son, who did turn out in the end to be autistic, and it turned out that my other 2 children were also autistic, and I've been diagnosed myself. In the process, 4 years ago, I went through a traumatic child protection situation where it was assumed that it was my mental health that was the problem. And I've spent a long time trying to understand and comprehend how people can be put in the position that we are as parents when we are trying to get the best for our children, and now in a position that are frightened to do so because of things that have been done to us in the past when, you know, we've been in a position that we don't know how to handle it. You know, I can be quite an articulate person, but I'm better writing things down than I am addressing things face to face. So I really want to put the question to you that there is families out there that find that they're completely in a position of being soul destroyed by prolonged outside agencies who appear to conspire but don't take ownership when proved wrong. Now, I was in that position and did nothing about it because I have no strength left anymore. All I wanted was an apology. I never got that. But I'm now in a position that all my autistic children show signs of hypermobility. And I'm in a position now that I am terrified to take it further because am I going to be subject to more stress? You know, there's kids out there that are suicidal, that have taken their lives because of professionals, and there needs to be a time that this stops. People need to start listening to parents, you know, because at the end of the day, we know our children better than anybody. That's my little sorry.
So absolutely, and on the positive side, there are also doctors like this, and I think it doesn't excuse that, because there are terrible, harrowing, unforgivable things happening to families out there in the UK and all over the world. And this is an opportunity to mention that we are actually bringing together a round table of experts that will be meeting at the Royal Society of Medicine in London in April, that are focusing on the paediatric issue that we are seeing all over the world. We're bringing together policymakers, members of the International Consortium, and members of the Paediatric International Consortium to try and tackle this head on, because it's not good enough. We need to make a difference. We're taking that challenge on, and we want to work together with everyone to try and make that better.
Terrible trouble with buttons here. I'd like to, we're recording this, right?
Yes.
I would like your permission, if we may, to actually use the way you've asked your question today, and to take it to this meeting as one of the examples of a real story with real compassion behind it. And I'd just like to, we'll check afterwards with you if you're all right with that, but I'd like to really thank you for asking that question. It's so pertinent.
I suppose in the meantime, I think, the way you asked that question was absolutely great. So I'd almost start there and think about going to your GP. And I've advised lots of people to do it. If you don't feel that your GP is helpful, unfortunately, I've had to ask a lot of people to try and change GPs. But really, if you can find one health advocate who is on your side, who can understand, and try and get that person to do as much as they can within the system, that would be really useful. I know that's not easy, but that's just one thing that you can do in the meantime before all this other stuff comes out.
So I have with that kind of depressing notion of that's going out there, something that is inspiring, of someone that's tuning in saying, I work as a physiotherapist and I want to help these patients live a healthy, active, independent life. I often struggle to manage patients' expectations of what we can and cannot do. When I ask, many patients tell me they want me to take their pain away, or a doctor has told them they need to go to a gym. This must be terribly frustrating for patients. How can we as healthcare professionals better manage patients' expectations of treatment options for EDS and HSD? So there are people out there willing to help us, which is great. Can we have an attempt at an answer on that question?
Well, I think we are, aren't we?
So how can healthcare professionals better manage a patient's expectations of treatment options for HSD? And your advice to a fellow professional? Better
manage the expectations. Well, I suppose the first thing is to have a conversation with the person that you're working with, your patient, as to what their expectations are. I think we spend a lot of our time looking at the current functional issues, various symptom profiles, thinking about our own expectations of our own interventions, goals to be set. Are these goals realistic over a period of time? What are the more long-term goals? So I think if you don't start with those sorts of conversations, it can be quite easy to go a long way down a pathway and have realised that you've never actually set a set of expectations. I wonder actually whether how many people in the room have gone into the room to a clinic, to a consultation with no expectation. Hands up if you've gone in with no expectation that anything was going to come out of it. Yeah, so it works both ways.
There are a lot of hands up.
There are lots of hands up. So work with your patients to identify the expectations and be honest about what you feel you can and can't provide. And equally for patients, everybody in the community, have in your own mind what you feel your expectations are. It's okay if they're under, because if we think we can do more, we'll try and boost you. It's okay if they're over, because if they're over, we need to have a conversation and bring them back down to something that's a bit more realistic. It doesn't matter either way, you've just got to have the conversation.
Absolutely. Is psychotherapy still useful if the patient has little childhood memory?
Yes. Yes, because there are ways of finding the memory. So using EMDR or EFT, there's ways of finding that memory. I haven't talked about it here, but also to some extent, hypnotherapy, you can find the memory. However, finding the memory is not necessarily so important. It's working with the present symptoms. So in the absence of the memory, what are the present symptoms? And are there any other memories that can be remembered that feed into the problem? And so with the CBT approach, you're always trying to work with the here and now. How can the person cope in order to relieve their suffering and distress in the present?
Thank you. Yes. Thank you.
Yeah, hi. Briefly, my work background is in mental health, and both as a nurse and as a social worker. 30-odd years ago, I had what was thought to be a very minor accident, and went to see an orthopaedic surgeon. I was told, can you bend over, touch your toes? Yeah, no problems. I mean, by this time, I was experiencing severe pain. I couldn't stand for more than about 5 seconds without blacking out. As I said, saw this orthopaedic surgeon, was told, asked, can I bend over, put my hands flat on the floor? Yeah, piece of cake, no problems whatsoever. The report that I got from the orthopaedic surgeon said any pain this woman thinks she might feel is probably a psychological reaction to her husband's death, coupled with a little bit of paramedical knowledge. As a result, I lost my workplace pension. I had to give up work. Sort of 35 years later, it's still impacting on my life because of the whole financial thing. And it's just this whole transition from being a respected mental health professional to just becoming this woman. And it was just an incredible experience. So yeah, just wanted to sort of share that it's not always good.
No, it's often not, and I'm afraid that I still see people in clinic who come with those sorts of stories. And there's a couple of things that come to my mind in your story. One is this perception that somehow, because you can move apparently more than normally, that you can't have sustained an injury is nonsensical. Equally, we were talking about earlier on today how you can dislocate joints and it not be painful. People who've got very unstable joints can dislocate their joints and it's not painful.
I actually had an L4-5 rupture.
Right.
But it was painful rather than natural.
So there are all these misconceptions around how pain and the mobility and the impact on function somehow should both track with each other. High levels of pain, clear evidence of reduced function. But the other thing that I do, somebody who has that kind of story, is ask the question, who wrote those things about actually formal, correct assessment of the diagnosis that they made and the statement that they gave, so that there was formal evidence that they'd worked this through. And I have to tell you that the vast majority of the time, the answer is no, they did not. And I have cases where people have been given various psychological diagnoses and there has been no formal assessment by that individual. I love my orthopaedic colleagues, but I doubt very much that any one of them would ever have the time, and very few of them would ever have the knowledge to do a formal psychological or psychiatric assessment in that way. The problem is, at the professional level, when that's down on a letter by Mr. So-and-so, who's a very important person in the local hospital, we're in trouble. And right now I spend my time getting those statements off people's letters because it leads to the kind of trauma that you've just described.
Hi, it was 2 questions if there is time. The first one was to do with the gut and the psychological and emotional health, what we eat, how our diet can impact on that. It was just to get the feedback from the panel and what they think on that.
Yeah, so this really brings us back, I think it's working out. This brings us back to the issue of the microbiome, and everybody's got a different microbiome and everyone has a slightly different reactivity to different foods, so it's a very complex area. I think it's true to say that we're just starting to understand it. So It's breaking news, really, and I think you'll see a number of the speakers that come to the Ehlers-Danlos Society, but even back in Ghent, we had a speaker go into great depth about this, and that's available, I think, for you to look at. It's incredibly complex, and we're only just starting to unpick things like celiac, carbohydrates, all of the mast cell activation, all of these things it's exciting times for those who are academic. It's not so good for people who are right in the middle of it, working their way through. And I think it's true that most of my patients work their way through to some kind of tolerable existence. But it's very, very difficult. And you never know quite when you're going to bump into something unexpectedly that's going to knock you out for days. So a very good question, but no simple answers.
At lunchtime I noticed there was about a third approximately that were for the special dietary requirements. So I don't know if a lot of people are figuring it out for themselves, that it's maybe having an impact. But the second one, if that's okay, was about time management. It was slightly touched on. If this is an actual problem within people, within the EDS community. I noticed again there was a lot of late comers, and I'm notoriously late. Everywhere I go, I'm late. I'll normally try and laugh it off, but it's embarrassing. It causes a lot of problems. But it's really whether or not this is like the actual physical challenges of the condition, as it's constantly changing. One day it takes 10 minutes to have a shower, the next day it takes an hour. It's managing the time that way, or is it an actual condition of time blindness? It's just to see what the feedback on that was.
Yeah, I would say the time management problems seem to be universal. My experience of this particular population is that time management does tend to be related to physical mobility and physical limitations, trying to get around. So while we can think about time management, particularly for people in relation to their work, from my experience, it doesn't necessarily, it can do, but it doesn't tend to come up much deeper than that, because it can go back to your childhood, but it doesn't tend to go much deeper than that in this population. So from my experience, it does tend to be because of the physical limitations around the body.
That's great. It's a relief to hear that. Thank you.
Hi, sorry. I think one question I'd like to ask is, I think a lot of people here would have spent a lot of money in the end trying to source the right doctors for their conditions. And it's knowing when to stop, when to actually realise that actually we're not going to get any further with the NHS at the moment, and we need to take this in our own hands and take a bit of ownership until we can then move everyone forward and bring everyone together. And I was wondering, have you got any advice what the best way is to collaborate everyone that you're trying to work with together?
Bring everybody together. As somebody who's worked in the NHS for many, many years and now works privately, I have huge amounts of sympathy with regards to access to people, and we see this both within the doctor side of things, the therapist side of things, podiatry. There are certain types of techniques that aren't even available on the NHS, right?
Two pain clinics.
2 pain clinics. So it's a very real phenomenon. One of the pieces of work that we've been trying to do as several groups, HMSA, EDS UK, the work we're doing with the Ehlers-Danlos Society, is at multiple levels work with the NHS to try and improve the understanding, the commissioning of services. So at one level, we're right up there talking to very senior commissioners at NHS England. At another level, well, let's not call it levels. In one place, we're talking to commissioners about how we improve services. In another place, people like Philip are going around Kent and educating and training and bringing networks together. We have the ECHO program that we're running, which is this all teach, all learn education program that anybody can jump onto from anywhere, whether they're NHS or private, it doesn't matter. We have masterclasses running up and down the country. So these are all ways that we're trying to sort of facilitate the development of much greater skills within a multidisciplinary team. Does it take a very long time? Yes. Even in the private sector, Professor Graham's still here, it took an extremely long time for us to gather our network together. But we had to start somewhere. And we're working closely with colleagues all over the country where they may be the catalyst for something. Philip was the catalyst for something in Kent. Maybe just sort of share your experience of what's happened in Kent over the last couple of years as an example of what can happen.
Yes, I mean, I've probably spoken to about 1,000 health professionals in Kent, including 200 GPs, and we give them this clear sort of outline of the questions you need to ask, the things to look for, and the simple things that you can do in primary care, like, if you've got POTS, take more fluid, more salt, simple things that make big differences, and things like mindfulness, things like Alexander technique, which we have got in our pain clinic. We've got Alexander teachers there, and kind of increasing the toolkit. And all three charities have been enormously helpful in allowing us to say, right, go and look at this, or there's this conference, come to Ghent, whatever it is, it's out there. One thing I did want to say about medical progress is that Alan and I have been through a period of time with a different condition known as rheumatoid, which we've got much greater understanding about. When we started, certainly when I started in 1980s, there wasn't really an effective treatment for an incurable condition. And at every clinic, you would have 3 people in wheelchairs who have just had totally destroyed joints. The picture has changed over my lifetime in the NHS to something which is now eminently treatable. And although we don't know enough about this condition, there is cause for optimism because so much international understanding and research is going on that I think there is cause for optimism for the future because things do change in medicine.
And I think to build an army, you need 1 or 2 leaders. And everywhere that we've been, where we have successfully started to develop programs and networks, there's usually been 1 or 2 people who have been catalysts. And they might come from doctors or therapists or other people. So if you know in your area of people that are sort of in the thick of this, but don't have a lot of support around them, that's where we were 10, 15, that's where colleagues are now. It's okay to start somewhere with very little and build. And one of the opportunities that we now have with the way we can network using virtual groups and everything else is that is so much easier to do in terms of having conversations with each other. A colleague of mine took a masterclass on physiotherapy up to North East England last week, 2 weeks ago, when we were at a staff meeting, and she ran a full program there. Fantastic. Loads of people there that were grappling with all the sorts of things that we've been talking about today. And I dialed in from 5 hours behind on the east coast of the States and joined in, and we all had a really good conversation. These things are easily done. It just requires people locally to have an interest. And if they're a catalyst, get them to contact us.
I just want to say thank you because I think it's about pulling the whole families together. We've talked a lot today about patient having that psychological support, but I also think it's very important for our partners too as well, because they're not just dealing with one, they could be dealing with children as well, and this up and down of the ADHD type of symptoms as well on top. And I just want to say thank you for the whole day anyway.
Thank you.
Off the back of that, I just wanted to ask, as we're here in Edinburgh and this particular country has a pretty poor demographic of EDS clinicians, is there any advice you can give to patients in Scotland, specifically people who are desperate?
I would say one piece of advice that I would give to anyone in Scotland and anyone listening from all over the world is tell the professionals, your GP surgeries, about EDS Echo that we've set up. Because that was set up to create 1,000 EDS experts by 2022 by this all teach, all learn model that's free to take part in. People can dial in from anywhere where they are in the world, present their de-identified case studies that could be people like you sitting in this room, to talk to experts to find out what the best care is for those people. And through that process, that's how you create more experts, because there's actually no such thing as an EDS expert. Doesn't exist. You have rheumatologists, geneticists, gastroenterologists, and on and on and on. And they are individuals that have taken an interest in this condition and been willing to educate themselves. And that's all we need, all around the world, more and more, because we still have a small collection of these experts that have dedicated their careers often to this condition, and for that we're so grateful, but we need many more. And everyone can help us do that and build that army of experts, because it's not impossible. It just requires their willingness to learn.
Yeah, can I tell you a little story about somebody who was brave enough to come down from Scotland to see me in Kent? And that initial consultation, I was able to kind of outline certain things that she needed to do. And I know that Julia has seen her. So she's had some Alexander lessons in Edinburgh. I then reached out to my gastro colleagues, because that was a big thing. I said, who do you know in Edinburgh who could deal with this? And so, so there was just two examples of kind of remote control, and she's doing really well. I think as our network increases, and a similar story from a ballet dancer who came to me who was going back to Madrid, or was it Barcelona? And I said, I know somebody in Barcelona, there's a professor out there, and we were able to plug that individual into the hypermobility network in Barcelona. So it's networking that I think makes the difference.
Yeah, absolutely. I can't do this afternoon.
That's it.
I've got some kind of motor dysfunction. Absolutely about the networking, and we're growing and growing that network, and part of the work that we're doing is extending the kind of international consortium with all of the expertise, and it's incredible once you do know. Sometimes I feel like a Yellow Pages. So people will come down to me in London and they'll say, you know, how are we going to do this? I actually already have many contacts. What I can't understand is why those contacts don't know each other locally. And I think one of the things that we need to try and do is get them networking closer together, however we can facilitate that. So network. We do know the people. I know there are people up here, because I'm referring people back up here all the time. But the other piece is the whole conversation with NHS Scotland and commissioning. And some of you will know from last year that this conversation did start, and NHS Scotland was looking at some of its data, which is the information it has on patients that are being transferred down to England for assessment. And I know that conversation is still happening. I did promise a couple of people who asked me a very similar question earlier on that I will email the colleagues that I've been in touch with, because they've spent time with me starting those sorts of questions, and it was one of those catalysts. So this isn't a clinical catalyst, this is a service delivery commissioning catalyst, and it started. It will take a long time, I have no doubt, because these things do. But there is this kind of undercurrent of work that's going on.
And to remind you all that we do have our medical directory, and we do have people from Scotland on there. So it's worth checking that out and seeing if there's anyone local to where you are.
Can I just add as well, if you're in sort of this area or north of England, we're very happy, and if you're interested in finding out about the Alexander technique, we're really happy to organise some workshops for people to get together and find out what it's all about.
See, there's a lot of people willing. You know, when we published the 2017 criteria, there were 90 people in the consortium. There's now 140. That's just in 2 short years. So it's growing. It is changing. We've all got, as a community, PTSD of this whole process of 20 years of no updated nosology, no real research, no funding, you know, and there is hope on the horizon now. It's just going to take a really long time to repair that damage that was done over such a long period of time. I've got time for 2 very quick more questions. So up there and then to the middle.
Hello. So I have a question regarding children. I have EDS myself. I was diagnosed 3 years ago. Recently my daughter has displayed some symptoms, which she was referred to our local rheumatologist at the Sick Kids in Glasgow. They said that she was a normal, healthy girl with nothing wrong with her, even though her collarbones dislocating, her shoulders, etc., other things. So I took her to see Professor Chikanza in July of this and she was given a diagnosis there. Going back to the GP, from seeing Professor Chikanza, he had asked for some specific tests to be done on my daughter, some extra bloods. And the GP, after seeing him and read the Professor's letter, he said there was a marked contrast between the local NHS rheumatologist and Professor Chikanza's letter, and that if I didn't mind, could he re-refer her for a second opinion. We were there yesterday, and again we were met with the same sort of attitude that she was quite normal. They agreed that she did need physiotherapy of some sort, but they said that there was a whole buzz, was the correct word, around EDS at the moment, which obviously is what you're trying to create, is a buzz and an awareness, which we all know. But she said that she was unwilling to acknowledge that she had EDS. She didn't think she had it. She wasn't going to label her with anything. She didn't believe in the Baton score assessment for children. I'm aware of the statement that came out from the British Society of Rheumatologists. I know that there was a letter sent back from yourself and EDS UK. So really my question is, does anybody know why there's such a reluctancy to diagnose a child, and why there seems to be this problem that they don't have anything wrong with them? Because today's all about the psychological and emotional health, and I feel that telling a child that they're perfectly normal, when my daughter's had to give up a dancing career, etc., she can't do certain things, what does that do to her mental health, to say that she's normal? And we don't have any services available. On one of the letters it was written that I had a shopping list, and that they were worried about me trying to get a medical diagnosis for her. So as again, we come back to the sort of child protection sort of issue. So it was really just to see whether anybody knew why the NHS rheumatologists are unwilling to address this.
Yeah. I think it is a real problem. I think it's probably the case that a lot of children who are hypermobile, that it goes away by the age of 14. That's what the paediatricians are saying. And that group who don't go on to get anything more complicated could be reasonably reassured. But the problem is, how do you know when it's an 8-year-old which way they're going to go? And Alan and I spend a lot of our time at the end seeing 25-year-olds who've had clues all along the way from that kind of paediatric contact, and then an orthopedic contact with subluxing kneecaps, and then an irritable bowel consultation with a gastroenterologist being fully investigated, and then all the way on the background there's been something suggestive of mast cell activation, and then they end up with us. So looking back, it's easy to say, well, why couldn't anyone have put this together? And I think that's a lot of what we're trying to do, is get the adult specialist at least to see those links. But with kids, it's another story. I've got 2 grandchildren, and my daughter-in-law is very hypermobile, and my grandson, who is 3, is not at all hypermobile. But my granddaughter, who is 1, is extremely hypermobile. Now, knowing what I know, I'm not too worried about her because she's walking and she's really active. And I suppose at the moment, what we're trying to do is say, don't protect those kids to the extent that they don't participate in exercise. Kids do better when they do more. But it's a very complicated area, and we don't have the answers. And you are right that some of our paediatric colleagues don't quite get it right. I've got one paediatrician in Kent who doesn't believe in POTS. Where do you start? It is complicated.
Absolutely. I mean, I think so. These are definitely other areas that we want to explore when we start our rounds of discussions with our paediatric colleagues. But we also have paediatricians, paediatric general physicians, and rheumatologists in our consortium, and we are exploring all of these areas very much. And the message that I get across, that comes across to me from them, I think time and time again, in particular, is in the younger children, typically say up to the age of 9 or 10, it can be very, very difficult to be clear what the diagnosis is, but that should never stop you treating whatever the problem is. So treat the problem, not the diagnosis, is a sort of way forward. And I can see the sense in that, because it can be very difficult to know whether a younger child will go on to fully develop many of the features of, say, hypermobile EDS, as opposed to the functional issues in the there and then, which may be very physical, which would be very typical of themselves of hypermobility spectrum disorder. But actually, if you spend your time almost concerned about the diagnosis and don't actually clock that you've got a youngster in front of you with a set of symptoms that's having a functional impact, then you've kind of missed the point, because the problem doesn't go away. Now, the other thing just to bear in mind is that actually we've had, so the British Society for Rheumatology has revised its guidance that it wrote in 2013, and that came out very recently. And broadly speaking, it's useful. It's got lots of very sensible suggestions, and it would be good to see whether those suggestions have actually been worked through to be confident that actually the whole assessment's been done. The other thing to bear in mind is that the College of Paediatrics and Child Health has actually endorsed the 2017 international criteria for a diagnosis of hypermobile EDS. So if the signs are there and the diagnosis is endorsed by going through the criteria, then that is the diagnosis. And the issue that you then have is you're possibly working with somebody who doesn't know that level of knowledge. So it's a knowledge gap.
Okay, thank you.
Okay, thank you.